So, welcome dear students. Today we will start and try to complete spleen. Okay. So, coming to anatomy of the spleen, it weighs around 75 to 250 grams, and as all of you know, it is in the left hypochondry. Another thing that is very important is the long axis will be lying along the 10th rib. That is important. It's actually wedged between gastric fundus and left hemidiaphragm. So, how it is, we will see. See, this is the fundus of the stomach. This is the diaphragm. In between the fundus and the diaphragm, it is there. So, it is, this is 9th rib and this is 10th rib. So, it will be, the long axis will be like this along the 10th rib. See the close and intricate relationships. One is the kidney, another is very closely the tail of the pancreas and the splenic flexure and the end of transverse colon and left colon starting. So this is also very important. They are very close. So there are so many ligaments here. One is with the diaphragm, linorenal, whereas another is linosplenic, and another is along with the kidney, there is splenorenal, and colon also, it is attached there. So these are the attachments. So another thing is, we all say splenic notch, but it is palpable only when there is splenomegaly. So splenic artery, as you know, it arises from celiac axis, and the splenic vein will join the superior mesenteric vein to form the portal vein. But can you tell me, before splenic vein joins the superior mesenteric vein, another important vein joins it. What is that vein? So before splenic vein, inferior mesenteric vein, very good. 1, 4, 3, you are correct. It is inferior mesenteric vein. So now you know the importance of the splenic vein and the splenic artery. You see the splenic artery, it is a very tortuous course it will have here along the superior border of the pancreas. So there you should be very careful, and before it reaches the hilum, it will divide into branches and then supplies. And few branches will be given to the, as already we knew, to the fundus. They are called as short gastric arteries. So this is the anatomy of spleen. Right? Now coming to the physiology, that is what are the functions of the spleen. All of you know about the immune function. It produces IgM, opsonins, properdin, and trypsin. These will help in phagocytosis of any foreign body. Then filtering function is also another important thing. All the cellular or non-cellular debris will be filtered from the circulation so that the blood supply is improved. Then there is what is called as pitting. This is, by this time I think you know about Howell-Jolly and Haynes bodies in the RBC. So they will be removed from the RBC, and that means their RBC are a bit cleansed in the spleen. This procedure is called as pitting. Then it will also have this reservoir function, mainly in children and even in adults also. 8% of red cells will be there in the spleen at any given time. And this function will be more pronounced in splenomegaly. Then cytopoiesis also is there. That is, there will be hemopoiesis, particularly in children, and production of T and B cells, macrophages, all these things. Can you tell me what is the name of this function? Can you tell me? Cellular filtration. What are the cells that are destroyed in the spleen, including the cells of the body also, they will be destroyed. That function is called as, yeah, they are RBC and macrophages, mainly RBC, platelets, everything. It is not called as phagocytic, no. There is a specific term. Whenever there is bird flu, they will be killing lakhs of birds. What do you call that procedure? It's a bit English actually. So, in swine flu, they will be killing the pigs also. That procedure is called as what? Difficult, huh? English. All of you are from convent, whereas myself is from so it is called as culling. Okay. So that function also, it is almost same to filtration. That is, they will be removing the dead and effete RBC, platelets, all those things. Okay. So these functions you should remember. So immune, filtration and culling, pitting, reservoir function, and production of some cells, cytopoiesis. So what are the investigations that are relevant to spleen? All of you know, because it has a role in both production and destroying. CBC is very important, particularly reticulocyte count. So then test for hemolysis, because there are some conditions, hemolytic anemias, where spleen will be grossly enlarged. So in those cases, you have to do this fragility test for spherocytosis like that. Then upper GI endoscopy, because splenic vein thrombosis, there will be varices, which can be well seen on upper GI endoscopy. Sometimes, because of calcifications in tuberculosis, you can see those calcifications on plain X-ray. But rarely we do nowadays for splenic conditions. Of course, it may be an incidental finding. But ultrasound is very, very important, both in trauma and elective cases. You want to know the size of the spleen, the consistency, that means the texture. Then, are there any cysts? All these things can be known by ultrasonography. Then, of course, CT and MRI mainly for the extent of the growth or the splenomegaly and other diseases. This is very useful in trauma. Okay, so you can also grade the splenic injury by CT. Then technetium 99 labeled colloid scan also is performed for specific problems. And finally, lymph node biopsy, particularly in leukemias, lymphomas, we do lymph node biopsy also. So these are the various tests that are relevant. If you remember CBC, hemolysis, ultrasonography, that is more than enough. So let us go to the congenital anomalies. So congenital anomalies, this splenomegaly may be given as a 2-mark question for you. So keep in mind, that means accessory spleens. Even in non-burn individuals up to a maximum of 30%, there may be splenomegaly. They are mainly at the hilum. So in the picture you have seen. So this is the hilum where there will be mainly concentrated 50% and tail of pancreas. Here another 30%. So in this region about 80% of splenomegaly are present. But what is their importance? So their importance is if you fail to identify them and then remove, the disease for which you have done splenectomy will be not be achieved because they will again the recurrence of the problem because of the splenomegaly. That is the importance. So you should search here for splenomegaly and then try to remove them if they are present. Then hematomas and splenic cysts are also there. These cysts may be true cysts or they may be cystic hemangiomas and lymphangiomas or even epidermoid and dermoid cysts. So these are the cysts. These cysts, as you know, may be generalized. In pancreas they may be seen, in liver they may be seen, but sometimes isolated like this in this picture, isolated splenic cysts may be there. Then you can remove them by splenectomy. So these are the congenital anomalies. But what is important is splenomegaly and hypersplenism. So hypersplenism is also a short note. That means 2 mark question for you. So when do we call splenomegaly? And so any enlargement is splenomegaly. But it is not a rule that every splenomegaly should be palpable, because unless the spleen is enlarged thrice its original size, it is not palpable. So this is important. This is in entrance, they may give this question. So 3 times. Then what is hypersplenism? So hypersplenism is splenomegaly associated with anemia, leukopenia, or all deficiencies. So RBC, WBC, and platelet deficiency. And because there is deficiency, there is compensatory bone marrow hyperplasia. So this is important. So this is what is called as hypersplenism. But that's not all. These conditions will have to be improved after splenectomy. Then only it is due to hypersplenism. So thinking that it is hypersplenism, you have removed the spleen, but the condition is not going to improve, then it is not they are not due to hypersplenism. So there are 3 components. One is there should be splenic enlargement. 2, there is anemia, leukopenia, thrombocytopenia, compensatory bone marrow hyperplasia, which will improve after splenectomy, right? So now let us go to the trauma. This is important. Rupture of spleen is mainly in examinations, they may ask you the rupture of spleen as a short note. So this is one thing that is important, is the first statement. Most common solid organ in blunt trauma. So first organ, that is most frequently injured organ, is spleen. Why? Because in some of the patients already spleen is diseased. Then it is very easy for it to get ruptured. Can you tell me the second commonest organ to be involved in trauma? Solid organ. It's an easy question, of course. Yeah, liver. Good, 81. You are correct. So first is spleen, next is liver. Now, So what are the causes of rupture of spleen? Because I just now told you that it is not only due to trauma, it is also due to disease. Already the spleen is diseased with malaria, something like that. Then it is very friable. Even single, it need not be trauma, single push may be enough. So there is an instrument called as larynx, where so with this, they used to exploit this condition that spleen is prone for rupture in disease. So in places where malaria is rampant, particularly in African countries and other places, of course, India is also there, but this instrument is mainly this. They used to use it as a weapon. So simply in the left hypochondrium, they used to push that instrument so that the spleen will be damaged. And in those days of no emergency surgery facilities, these patients used to succumb. So that is one way of homicide. Then sometimes spleen can rupture spontaneously also. So these are the causes: trauma, disease, and spontaneous. So what are the occasions where spleen can be traumatized? One is, as already we know, it is road traffic accidents, mainly blunt or even stab injuries. Then surgery. So while doing surgery, because already I have shown you the intricate anatomy, it is so close to stomach, kidney, pancreas, colon. So whenever you do surgery on these four organs, the spleen is going to be injured if you have not taken proper care. So surgery is, of course, it's a different matter that during gastric surgery we remove spleen sometimes, but that is purposefully. Whereas this is, that is deliberate. Whereas here it is accidental injury of the spleen during surgery. Then disease means, already I told you in malaria, tropical splenomegaly. We'll come to that later. So in these conditions, there is the spleen is more prone for rupture. Now, what are the types of injury of the spleen? One is, it is a subcapsular hematoma. That means just beneath the capsule of the spleen, there will be collection of the blood. It will, just like contusion on the surfaces. So it will get absorbed, but there is a problem with the subcapsular hematoma. We'll come to that later. Then incised, that is stab injuries. There may be incised wounds. Then blunt injuries, there is laceration of the wounds. So hilar injuries means directly at the hilum, it may be injured so that it is devoid of vascular supply and there will be torrential bleeding and the spleen is useless. So in those cases, you have to remove the spleen. So these are the types of injuries: subcapsular hematoma, incised wound, laceration, and hilar injuries. So frequently, as I told you, it is associated with, suppose there are fractured ribs, then you have to suspect rupture spleen. Other way also, whenever there is a rupture spleen, you have to think of left lower fracture of the ribs. Okay. Then injury of the diaphragm because it is so close. Lungs also superiorly, pancreas, left kidney, colon, all these injuries may be associated. So the treatment depends, rupture of spleen, depending on whether other associated injuries are there or not. Okay. So it is not simply enough for you to do splenectomy and then come out. You have to examine for other organ injuries also whenever you open the abdomen, right? Because some injuries may not be picked up by even CT scan, right? So what are the clinical features? Of course, there will be pain. Then this is very important. This is not only important practically, even academic wise. This may be given as an entrance bit. Ker's sign is referred pain in left shoulder. Whenever there is injury to the spleen because of bleeding, the diaphragm is irritated. So the diaphragm, which is supplied by phrenic nerve, it is the dermal component of this phrenic nerve, that is 5, C5 is there in the shoulder. So there will be referred pain in the left shoulder, that is called as Ker's sign. Okay. Then because of bleeding, hypovolemic shock, there will be shock. Then tenderness, if you palpate there, rigidity in that region, left hypochondrium mainly. And gradually it will lead to distension because there is hemoperitoneum. So hemoperitoneum means blood in the peritoneal cavity. Then another sign that is not frequently mentioned is balance sign. This is not balance. This is name of, just like the other day we were talking about dance. Some of you thought it is some kuchipudi dance. No, that is dance is person. Here also balance is a person. So that's why balance is a sign. So he is a surgeon who has invented this sign called as a balance sign, that is non-shifting dullness in the left flank. So usually when we make the patient in ascites or even in hemoperitoneum, if you make the patient to lie down on right lateral, then the left flank will become empty, and then there will be this dullness will change to resonance. Whereas in kidney, this splenic injuries, non-shifting dullness, if at all it is present, it is very suggestive of splenic injury. So that is called as balance sign. Then I was telling you about capsular, subcapsular hematoma. So one danger with it is the patient after minor trauma may be bleeding into the subcapsular space, and then he may be normal. After 2 to 3 weeks, suddenly this will give way, the capsule of the spleen, thereby resulting in massive hemorrhage into the peritoneal cavity. That is called as delayed, that is due to delayed rupture of subcapsular hematoma. It can also result in shock and all. So after 2 to 3 weeks of injury. So that is called as delayed. Okay. Now, what are the investigations? One thing is, already I talked about this FAST. That is focused abdominal sonar for, or sonography if you want in English, sonography for trauma. So this is done both in any emergency trauma condition, mainly to detect the solid organ injury like liver, spleen, and hemoperitoneum can also be seen. So of course, CT is the investigation of choice once the patient is stabilized. If he is not resuscitated properly, if you take CT, take him to CT, then it is detrimental to the patient. So of course, according to CT, there are 5 grades depending upon the extent of injury. This 5th grade is equal to the hilar injuries or shattered spleen. Just like shattered kidney you might have heard in renal injuries. Here also shattered spleen is 5th grade. And what is the advantage? Already I told you, you can have You can see other injuries also, like pancreas, kidney, all these things. You can, even diaphragmatic injuries can be picked up by CT. Of course, previously when we were not having this facility, used to take plain X-ray, which will recognize, of course, the fractured ribs. It can also recognize a soft tissue shadow, absence of psoas shadow. That is very important on plain X-ray. But nowadays, we are having everywhere CT scan. So the role of plain X-ray is now limited. Previously, when we were not having even ultrasound, then we used to do this TPL. So peritoneal, this tap we used to do. So this will be useful paracentesis to detect the blood in the peritoneal cavity. But the role of these last two is now limited with the use of both fast and CT scan, right? So what do we do? How do we treat splenic injury? So first thing is, as I already told you, resuscitation. So you have to immediately institute IV fluids with a broad or thick cannula, and then pump fluids, and then send blood for cross matching. And then here we can have one very important measure in this regarding hypovolemic shock. So this is limited only to splenic injuries. Why, I will tell you, but first let me know what is that measure in splenic injuries whenever the patient is having hemoperitoneum and there it is due to splenic injury. What can be done? On laparotomy, of course. After laparotomy, we can take a measure when there is a loss of massive volumes of blood. So what we can do? I don't think you will answer this. Yeah, somebody has answered. Good. I'm happy. Embolization, I told you specifically it is after laparotomy. Embolization of splenic artery you can do provided there are facilities. But we don't have that facility, isn't it? I told you clearly, there is, I have given you a tip also, there is loss of blood and you have operated the patient. Of course, if you hear it, so simple answers are as told, you will think, but it should strike you. IV fluids already we have known, isn't it? Yes, aspiration. By aspiration, what will you achieve? You are aspirating, okay, but what will you achieve by aspiration? Ligation. No, it is very difficult for you, I think. So it is. If I write the first word, you will answer. Yes, now you tell me. Written the first few letters. Now you try to answer this, all of you. We have answered 4881, 47, 104. You try to answer. I have written the first one already. Auto. You have opened the abdomen, there is blood loss. So what you can do? Still you are unable to answer. Too bad. Very good. 81, you are correct. Yes, auto transfusion. So this is very important. measure, because of course in those days blood was scarce, not available in plenty. Nowadays it is a bit better, but in those days where blood availability was not that much, we used to rely on auto transfusion. So we used to filter it and then transfuse it back to the patient. Of course, there are few slight side effects like fever and all, some allergic reaction, because however sterile you do this procedure, still it is a problem, minor problem, of course. But why we are not able to exploit that for other organs like liver? Okay. Liver, pancreas, of course, pancreas may not be that much necessary. For liver and kidney, why we cannot adopt this auto transfusion? Now you try to answer. They are also solid organs like spleen, but why we cannot do the same auto transfusion for yeah, you have answered for it. It is just be in line. చూస్తాను. ఓకే 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 అది నేను ట్రాక్ చేస్తాను. చేశారు. ఓకే, ఏది మీరు కాలేజీకి పంపించిందా? ఓకే, థ్యాంక్ యూ. నేను ఇప్పుడే పంపిస్తాను. అలాగేనండి, అలాగేనండి. థ్యాంక్ యూ వెరీ మచ్ అండి ఫర్ యువర్ ఎఫర్ట్స్. అదే అంటే ఆయనకి చెప్పాను కొన్ని పర్సనల్ ఏంటంటే ఆయన నేను మాట్లాడతాను, అంటే నేను మాట్లాడతాను. అదే నాకు తెలుసు కదా. థ్యాంక్ యూ అండి. నాకు పంపించారు కదా, నేను చూస్తాను. చూస్తాను. థ్యాంక్ యూ. అలాగే, థ్యాంక్ యూ. Oh, sorry. Now, so it is, there are other products like for liver there is bile, for kidney there is urine. So that's why we are not supposed to transfuse this blood, right? Now, antibiotics, of course, self-explanatory, whereas vaccine, we'll talk about it more later. Now, previously, splenic injury means we used to do splenectomy, direct, without any. Even for liver injuries, we used to open the abdomen and then close them, only to find that bleeding is already stopped. So, to prevent this unnecessary laparotomies, now for liver, almost non-operative measures, whereas for spleen, for grade 1 to 3. So, in those patients, we can try non-operative measures. Whereas for grade 4 and grade 5, already told you, shattered injury, grade 4 where there is this laceration which is occupying huge areas of the spleen, then you are supposed to do only splenectomy. Another thing is, if the patient is stable, that means bleeding has occurred but stopped. Now the patient is you have revived him, and him or she, of course it's mainly him only, because only males are adventurous. So but I don't know about present condition anyhow. So then, so if the patient is stable, is maintaining stability, then, and if the injury is only limited to spleen, only spleen, okay, in those conditions, you have to do conservative treatment. You can rely. Whereas, what are the indications for spleen, splenectomy? Unstable patient, you are unable to revive him, however best you are trying, grade 4, grade 5, and other injuries which need to be tackled, you have to do laparoscopy. So, what are the types of surgeries on the spleen on laparoscopy? So, this is mainly for trauma. So, splenography, just like we repair hernia, herniorrhaphy, here also what you can do is splenography. Suppose there is a tear or laceration, you can simply suture it back, provided there is no bleeding, further bleeding. So that, or you can attach some glue to the bleeding point, or you can put some sponge. All these things come under splenography. That is repair of the injured spleen. Partial splenectomy, just like partial nephrectomy, you might have heard in injury of the kidney. Partial splenectomy, you can remove half of the spleen or 1/4 of the spleen, 1/3 of the spleen, like that. It's called as partial splenectomy. Then total splenectomy. So these are the three things which you have to remember. One is splenography, another is partial splenectomy, and finally splenectomy. Okay, what are the complications of splenectomy? This is, I'm talking only for trauma. Actual complications will come later. So, hemorrhage, of course, self-explanatory, need not be due to the primary injury. While doing also, there is a complication of hemorrhage which can lead to disseminated intravascular coagulation and even sepsis. Then, splenic arteriovenous fistula. This is another complication. Then splenic artery pseudoaneurysm. These are the ones mainly seen in emergency splenectomy. That's why I have put it here. So these three complications you have to remember whenever you think of emergency splenectomy. Now let us go to this more important topic, that is, what are the causes of splenomegaly? So this is mainly keeping a surgical point of view. So this may not be too extensive because there are so many other diseases of the spleen, diseases where there may be splenomegaly, but this is keeping surgery in point of view, and you will see asterisk marks where splenectomy is indicated. So this slide you have to keep in mind, and at least remember these diseases for which there is asterisk. That means these are, in other words, indications or splenectomy can be done in these cases. So let us classify the causes of splenomegaly. So there may be a question, classify the causes of splenomegaly, and then indicate the conditions where you can do splenectomy. So let us classify them. First is infective. In infective, first is bacterial. So bacterial, typhoid, there may be splenomegaly. Tuberculosis, especially involving the spleen, is there. It can lead to splenic abscess also. Then splenic abscess due to other bacterial, acute bacterial conditions. And for example, you have this condition called as subacute bacterial endocarditis, where there may be infective emboli going to the spleen, thereby resulting in splenic abscess. Then, of course, spirochetal, Weil's disease, syphilis, viral infectious mononucleosis, and even in HIV, there may be splenomegaly. Then protozoal and parasitic. Of course, all of you know about malaria, schistosomiasis, Kala-Azar, trypanosomiasis, hydatid disease, tropical splenomegaly. So here in infective conditions, if you see, you can do splenectomy in tuberculosis. Of course, it's previously we used to do even in splenic abscess. Then schistosomiasis where it is rampant, that is another indication. Then hydatid disease, rarely spleen can get involved in tropical splenomegaly. So these are the conditions of infective causes of splenomegaly. So diseases of the blood like leukemias, both acute and chronic, and these are all hemolytic anemias, hereditary spherocytosis, autoimmune hemolytic anemia, thalassemia, sickle cell disease, ITP, that is idiopathic thrombocytopenic purpura. I hope in medicine they have covered all these diseases in detail because we are not going to cover them in surgery. So if they are not covered in medicine, please ask your HOD medicine to cover these topics because in surgery we are not going to touch them apart from mentioning them as indications for splenectomy. So once again, the indications are hereditary. These are all hemolytic anemias. Hereditary spherocytosis, autoimmune hemolytic anemia, thalassemia. Of course, in sickle cell disease, actually there may not be splenomegaly, but sometimes splenectomy will result in improvement of the condition. Then ITP, of course, all of you know this. Now coming to metabolic diseases, rickets, amyloid, porphyria, and Gaucher's disease where there is accumulation of huge quantities. So here, Gaucher's disease, one of the indications for splenectomy. Then circulatory, of course, just now I told you about infarcts and portal hypertension. So whenever there is carcinoma of the pancreas or splenic vein thrombosis, they are indications for splenectomy. Whereas portal vein, other reasons. Can you tell me one condition, not one condition, one operation where splenectomy is done as part of portal vein? In medicine, they might have told you. So what is that shunt which is in which splenectomy is done? There is a shunt in which splenectomy is done. Portal vein is, in addition to medical treatment, there is surgical treatment also. Yes, let me see the answer. Portocaval, they are shunt surgeries, but in portocaval we don't do splenectomy. There is another shunt that is called as so this is a splenorenal shunt. Yeah, now you are answering. All of you are answering. Yes, good. At least now you have answered 1, 4, 3 and 4, 7. Good. So this is also called as Warren's shunt, where you do splenectomy and anastomose splenic vein to the renal vein. That is called a splenorenal shunt. Okay, so that is another indication. Of course, carcinoma pancreas, there may be portal hypertension. Splenic vein thrombosis itself can cause, due to various reasons, portal hypertension. In those conditions, you can do splenectomy. Now, collagen diseases, of course, Stills and Feltis. What is this Feltis? Feltis syndrome, what is it? In medicine, you might have heard. Yeah, good. So, 8-1 and 4-8 has answered partially. 1-4-3 has answered it. Yeah. So, neutropenia and rheumatoid arthritis, splenomegaly is there. Then you will do splenectomy. That is Feltis. In a nutshell, it is rheumatoid arthritis with other problems, extra arthritis problems are there. So Feltis. Now, non-parasitic cysts also, just like parasitic hydatid cyst. Already I have shown you non-parasitic cysts, which are mainly congenital. Then neoplastic, of course, there may be huge hemangiomas and Hodgkin's lymphoma previously, not now. Previously, when there was no CT scan for staging of Hodgkin's lymphoma, we used to do splenectomy. That's why it was called as staging splenectomy. Nowadays, we rarely do, unless indicated, splenectomy in Hodgkin's lymphoma, because main treatment essentially is chemotherapy and to some extent radiotherapy, right? So these are the indications. Please remember at least headings, infective, and headings and indications for splenectomy. So infective tuberculosis, splenic abscess, schistosomiasis, hydatid disease, and tropical splenomegaly, very, very important condition. Blood disease, hereditary hemolytic anemias and ITP. Metabolic Gaucher's disease, circulatory in Warren's shunt and carcinoma of the pancreas, splenic vein thrombosis, collagen diseases, Feltis syndrome, and neoplastic, of course, rarely Hodgkin's lymphoma. So these are the causes of splenomegaly. Now, surgically important is splenic abscess, so we will deal with it. So this is again, as I told you, infected embolus, one of the most common causes, and of course in typhoid, tuberculosis, and osteomyelitis. So various causes of primary source of infection, like even otitis media. Of course, pancreatic necrosis is nearby. So these are all the causes of splenic abscess, intra-abdominal infection also. So they can produce splenic abscess like that. So what is the difference? How can you say that this is abscess, not cyst? I've shown you cyst also. I will, for your benefit, I will again show you splenic cyst. So this is splenic cyst. Multiple splenic cysts are there. Whereas this is an abscess. How can I say that this is splenic abscess? Because there is heading, or are there any features of splenic abscess in this slide? So by nature of the abscess, I can tell you. Can you tell me what is that nature by which I have identified that it is splenic abscess, not splenic cyst? So for that, you need to know about CT scan to read these CT scan reports. Yes, they are space occupying, even cyst also is space occupying. What is that special feature or the characteristic of abscess? Cells in abscess, how can we identify on CT scan? You are correct. If I aspirate it, okay. So after aspiration, you are correct. Why pus cells, even frank pus can be aspirated. So what are the CT scan features of abscess and cyst? That is important. So two features are important. One is if you see the acoustics. See, this is less this one. Black, isn't it? It is almost gray. Whereas in here itself you can see it is so black. So of course this is not completely fluid. This is air also is there. Even contrast is there. So but anyhow, so you compare this blackness with this. Cyst will have almost not this much, but definitely blacker than this. That is one thing. Second thing is the margin. In cyst, the margin is clear cut unless it is malignant. Whereas here, if you see, it is hazy. So these are the well-defined capsule in the cyst. Yeah, you are correct. 143. So these two conditions are very important. One is the haziness, another is hazy margin. So this is splenic abscess. The problem with it is if this ruptures, there will be subphrenic abscess. So subphrenic abscess, again, it needs to be treated in a different way. So what is the treatment? First, you treat these conditions. That is very important. If you treat them, it can get recurred. So first treat these conditions. Primary source of infection needs to be corrected. Pancreatic necrosis is there. You have to do necrosectomy. Intra-abdominal infection is there. You have to do laparotomy, clear the infection. Do peritoneal toilet. Whereas if they are already dealt, the treatment for this is aspiration. Previously, we used to do splenectomy, but first we will try under ultrasound guidance, aspiration, send it for culture and sensitivity, and then give antibiotic accordingly. Of course, if the spleen is almost destroyed with this abscess, no other go but to do splenectomy, right? So that is about splenic abscess. Now, there are certain conditions where there is massive splenomegaly. I used to remember in my UG days as MMTT. So I am reproducing that. Malaria, myeloid leukemia, thalassemia, and tropical splenomegaly. I was mentioning about this so many times. Now, what is this tropical splenomegaly? It is nothing but splenomegaly in tropics. Most probably, this is not the rule, but our presumption is it is mainly due to malaria, Kala-Azar, or schistosomiasis. So, tropical splenomegaly with hypersplenism is the indication for splenectomy, right? So, these are the causes of massive splenomegaly. In the exam, if there is splenomegaly case, so lump abdomen, the splenic enlargement is there, your diagnosis should be these four. Nothing more than this you should talk. Okay? Probably the patient is suffering with these diseases, you have to tell. Okay. So now let us go to the actual thing, splenectomy. So we'll be asked about splenectomy in the exam. It is a theory question also. Indications for splenectomy or complications of splenectomy as a short notes. So you have to remember all these indications. One is most common, of course, all of you know, is trauma. Either already I told you, is it due to accident or surgery on the various organs. Already told you about stomach, pancreas, or splenic flexure. So whenever you are operating, you have to take care of spleen. Otherwise, it may get injured. Removal en bloc. So this is, here it is accidental, whereas here it is deliberate. Removal en bloc in radical gastrectomy, upper radical gastrectomy for carcinoma of the stomach, or carcinoma of the pancreas, where you want to do distal pancreatectomy, total pancreatectomy. So in those conditions, you may actually, depending whether you are doing splenectomy or not, this gastrectomy is classified. So that's why here removal en bloc means mainly due to carcinoma. Okay. Then due to various causes of this anemia or thrombocytopenia, that is hemolytic anemias and ITP. These are all the causes already you have seen. Spherocytosis, ITP, hypersplenism, where there is leukopenia, anemia, thrombocytopenia. Then also you have to do splenectomy. Already talked about shunt surgery, that's Warren shunt. So these are the indications: trauma, tumor, hemolytic anemias, and portal hypertension. These are the indications. Now, how do we do splenectomy? But it is not a simple affair doing splenectomy. You need to prepare the patient before splenectomy, mainly vaccination. This is very, very important. We'll talk about it later. Then antibiotic prophylaxis. Of course, all those capsulated organisms you have to give. Penicillin derivatives is the best. Our pharmacology professor is also there, right besides me. So if I talk more, he may question me. So antibiotic prophylaxis, then transfusion of the blood. Already talked about autotransfusion, in the role of autotransfusion in trauma. Then FFP, cryoprecipitate, platelets, all these things you need to be corrected preoperatively before you venture splenectomy. Now, what are the techniques? Of course, nowadays laparoscopic splenectomy is getting more popular. Of course, we are still doing open only, and open is also again two types. One is elective, another is emergency. In elective, you have time to prepare the patient, whereas in emergency, you have to be very meticulous. Immediately, you have to catch hold of the artery and then ligate it. So the incisions we give are either a midline supraumbilical incision or transverse subcostal. So these are the two incisions I will show you. So one is vertical midline supraumbilical incision, which gives wide access for all other organs. Whereas if you are sure that it is only spleen, nothing but spleen injury, then you can give a subcostal, left subcostal incision like this. But in children, it's mainly the transverse incision. So these are the three incisions we give. In children, it is always transverse incision, whereas in adults, either a vertical midline or a subcostal incision, right? Then laparoscopy I have told you, but the approach is different. In emergency, I told you, immediately what you have to do is put your hand here. I will again, I will again go back to this slide. Here you are seeing the diaphragm here. This is spleen. So you have to put your hand here. So your right hand should be here and then bring the spleen into the operative site. Then whatever vessel that is coming into the spleen, you have to ligate and then be done with it. So the approach is like this in a trauma. Whereas in elective cases, what you do is first identify the splenic artery by opening this sac called as lesser sac. So what is this lesser sac? What is this lesser omentum that is there? In between what structures there is lesser omentum? Please tell me. What is this lesser sac and lesser omentum? So all of you know that lesser sac is behind the stomach. So what ligament you have to cut before you open the lesser sac? Not a difficult question, but I am not finding any answers. Yes. So one answer is falciform ligament. Another answer is hepatogastric. Another is gastrosplenic. All are wrong, but 4-8, you are correct. It is gastrocolic. Okay, gastrocolic. Actually, so what we do is between the stomach and colon, if you open, then you will enter the lesser sac. So once you enter the lesser sac, you have to identify the pancreas. Above it, there will be the splenic artery. You ligate either here or multiple ligations here, ligate the veins here, and then remove the spleen. So that is for elective. Whereas for trauma, once again, I am repeating because it's worth repeating. You have to put your hand immediately, bring the spleen out, and then ligate whatever is entering or leaving the spleen. So that is because in emergency, your main aim is to control bleeding. Okay, so that's how you can do splenectomy. So this can be achieved even by laparoscopic, even trauma. They are doing nowadays laparoscopic splenectomy. Now this is very, very important. It is given a number of times, both 2 marks question and sometimes even 4 mark question also. So post splenectomy complications, very, 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 very important. Always, I go on repeating also, always classify. If you simply enumerate, first you will tell, sir, there are 10 conditions there. Then you will remember 5 conditions. And once you try to tell them, you will tell only 3 conditions. So if you classify, first is intraoperative. What are the intraoperative? Then immediate after surgery. Then early after surgery. Then delayed after surgery. These are the classifications of complications of splenectomy. So intraoperatively, of course, hemorrhage, primary hemorrhage is common. Injury to other structures, just like while operating on stomach, pancreas, colon, how spleen can be injured. Actually, this is more common. When you are dealing with spleen, stomach, pancreas, colon can be injured. If you blindly keep a clamp in your anxiety, sir, this is emergency, sir, then you are likely to clamp pancreas at the hilum of the spleen. So, injury to other organs, surrounding organs. Then immediate post-op is hemorrhage. Again, this is mainly called as reactionary hemorrhage. That is slippage of ligature, or there is increased while closing the abdomen, the patient's BP was 90. Whereas you have dumped fluids and this BP has jumped to 140, then what will happen is there will be more bleeding, or the ligature will be slipped, because with each pulsation the ligature will shift to the from the end to the periphery. So there may be likelihood of slippage of the ligation. Then of course hematemesis, because of injury to the stomach, there may be hematemesis. Frequently this is the complication that will occur, gastric dilatation. Because of sympathetic reaction, stomach will be dilated. So you cannot institute immediately oral fluids. At least trials tube till surgery you have to keep. Some people keep it for 1 day, but of late we are removing after surgery. But you have to be careful about dilatation of the stomach. Okay, whenever there is dilatation, you are not supposed to give oral fluids or feeds. You have to again put back Ryle's tube and then aspirate till the stomach gets settled. There should not be any gastroparesis. Then, because left basal kidney is there, not kidney, lung is there, there is chance of atelectasis. Similarly, pleural effusion, left pleural effusion. So these are immediate complications. So once again, hemorrhage, reactionary mainly, hematemesis, gastric dilatation, left basal atelectasis, pleural effusion. These are the immediate complications. Then early complications are sometimes by ligating the short gastric arteries and veins, you have injured the stomach. It will lead to gastric fistula. Similarly, you have injured pancreas, pancreatitis. Then, because this spleen is already, we talked about thrombocytopenia. Once spleen is out, there is thrombocytosis, which can lead to increased tendency to clotting. So you have to put aspirin. Now, then is delayed. Delayed complications are post-splenectomy septicemia. This is important. This is a 2-mark question for you, called as OPSI, that is opportunistic or overwhelming post-splenectomy infection. This is very common. So that is because of reduced IgM tufsin, reduced phagocytosis of capsulated, that is that is staph pneumoniae or Neisseria meningitis or Haemophilus influenzae and E. coli. So the patient will have reduced this phagocytosis, so they may prevail. These infections may prevail. So I'm sorry, I said staph, it is streptococcus. Okay. So what is this OPSI? Overwhelming post-splenectomy infection. This can occur mainly in children where immunity is not well developed. So that's why this corona is not affecting mainly the children, because there is deficiency of immunity. The main problem in this corona is cytokine storm that is not occurring in children. In fact, they are all hale and healthy even though they are infected. So that is the advantage in corona, whereas in splenectomy, after splenectomy, the problem is they are having well-developed immunity. So they are more prone. So compromised immune function, at least for 2 to 3 years after splenectomy, you have to be careful about these infections. So what you can do is, again, immunization for them. These vaccines you have to give. And then of course, antibiotics, prophylaxis, like penicillin group is best. Either penicillin, erythromycin or coamoxiclav nowadays we are giving. So Not only that, you have to educate the parents regarding this splenectomy. So that is important. And then whenever there is any mild infection also, you are supposed to treat them well. Otherwise, the patient may land in this abscess. So what we have to do? So what we have to give is anti-pneumo or meningococcus C. Every 5 years you have to give. Immediately you have to give. Later, every 5 years you have to give anti-pneumococcus, anti-meningococcus C vaccine. Similarly, H influenza type B, HIB it is called as, this can be given every 10 years vaccine. So, in emergency, because there is no time, whenever it is available, either just before or after surgery, you have to give this vaccine. Whereas in elective, it's always better you give vaccine, wait for 2 weeks, then go for surgery. Because even surgery can lead to complications, infective complications sometimes. That's why elective, because you have time, you can wait for 2 weeks after giving vaccine. Whereas in emergency, because that is more important, you have to immediately give it whenever it is available, just before or after surgery. So another thing is in endemic areas like even in India and South India also, anti-malarial prophylaxis is also important. Then another thing is, already I told you about education. So whenever the patient is splenic, what you have to tell them is they have to carry a medical alert. That is, I was splenectomized. So I need specific attention for that. Similarly, about vaccination card also. Of course, this is another infection that in addition to these infections, capnocytophaga, this is actually canimorsus. Yeah. So this can be acquired from dogs and cats. So this infection is also post-splenectomy patients are mainly affected. So this is for entrance purpose I have included, otherwise not important for our routine discussion. So in view of these complications, what is the remedy for that? So the remedy is try to preserve the spleen. Already talked about splenography, partial splenectomy. And if at all possible, you can preserve the spleen completely. So treat conservatively. If the patient, already I told you, the patient is stable, sorry. So if the patient is stable and it is only grade 3 up to grade 3 and it's only spleen, what you can do is you can preserve the spleen so that you can preserve the spleen. But if at all you are supposed to operate, what you can do is you can do splenography or partial splenectomy, right? So for today, that's it. If any doubts, please inform me, ask me. Just 1 minute. Hello? Monday? Sorry. Thank you. So any doubts are there? So this is very important. Please read this once or twice. Post-splenectomy complications or simply OPSI also they may give as 2 mark question. So the essential steps are mainly in children, at least first 2 to 3 years, you have to give prophylaxis, and the antibiotic is choice is penicillin group. Vaccine, both anti-pneumococcus and meningococcus, it is combined preparation is available. H influenza B also, right? And finally, preservation of spleen should be our main aim to prevent opsy, either conservative treatment or splenography or partial splenectomy. Yes, no doubts. As I tell you, either you are very much thorough, better than me in spleen, or nobody has listened to today's lecture. Then only there should be no doubts. Otherwise, there should be plenty of doubts in spleen. All of you are already withdrawing. The number is dwindling already without any doubts. Okay. Right. Thank you.